Today is Tuesday, November 10, 2020, and we are going to be covering Module 1A on Semen Analysis. My name is Ashok Agarwal. I am the host of this program for the next 2 hours. So welcome to all of you, and we are ready to begin now. I want to declare that we don't have any conflict of interest. As you can see, the program was completely organized by the support from our center, and no companies or outside entities were contacted for any kind of sponsorship. Webcasting was supported by our Cleveland Clinic IT division, David Reichling and David Wolfley. Course faculty have donated their time for this online training. Program coordinators, and we have 7 of them who have volunteered their time for this training. And more importantly, the names, images, and description of certain products or instruments which you will see during the lectures are being used routinely in our andrology lab, and we are not endorsing any of these as speakers. So today's program is going to be including Module 1A, which is Manual Semen Analysis, which you have seen in the announcements that we have provided you. I am in charge of the andrology program at Cleveland Clinic, and I'm also the director of the American Center for Reproductive Medicine. I wear a couple of different hats. I am very much involved in managing the diagnostic lab of the Cleveland Clinic, as well as our program in male infertility research in Cleveland Clinic. We are recognized as the #1 program in the world in the fields of male infertility, andrology, and human-assisted reproduction. And this is based on the number of peer-reviewed publications, based on the number of citation scores that we have, and also based on the H-index. And these are the numbers that anybody can check anywhere in the world. If you go into Scopus database that rates every single researcher or author in the world. We have a large number of medical textbooks that we have written. More importantly, our program has trained over 1,000 scientists, clinicians, graduate, undergraduate students from United States and from all over the world. So I'm very fortunate to be running this program along with the very talented team of people who you will meet some of them today. I spent about 10 years at Harvard Medical School, where I was the director of male infertility research in urology at Brigham and Women's, and also an assistant professor at Harvard Medical School. So now let's talk about the program. That is enough of my introduction. Neel is a urologist who specialized in male infertility. He did a fellowship here at Cleveland Clinic in our department, and he is now on his staff of the Cleveland Clinic Department of Urology, and he has a major practice in male infertility, and he is going to be actually discussing the interpretation of lab results in the clinical management. So let us start his presentation. From here. Neel is actually in his surgery, so today is his surgery day, so he has was very kind to record his entire presentation after we communicated with him. So you will hear his presentation, which is very, very well prepared.
Hi everyone, my name is Dr. Neel Parekh. I am a clinical assistant professor in male infertility and andrology at the Cleveland Clinic. I have the opportunity today to discuss the clinical interpretation of the semen analysis. Unfortunately, I wasn't able to be with you live today, but I look forward to sharing my thoughts throughout this presentation. I'm going to begin the lecture by discussing the first step in the specimen collection, and that begins with counseling patients on the appropriate abstinence interval prior to their semen collection. Now, the appropriate abstinence interval should be a period of 48 hours, but not more than 7 days. There is some evidence to indicate that an abstinence interval greater than 7 days may result in higher levels of sperm DNA fragmentation. Next, the sample should be obtained via masturbation. If the sample is collected off-site, the patient should deliver it to the lab within 30 minutes to 1 hour, and it should be kept at body temperature during transport. Patients should be counseled to avoid lubricants during the process, as they can be spermaticidal. And finally, coitus interruptus is not an acceptable means of collection, primarily because the first portion of the ejaculation has the highest concentration of sperm, and that will be lost, and the vaginal fluid has an acidic pH that can adversely affect sperm motility. The remainder of the lecture will be broken up into a number of clinical questions. Our first clinical question today is, what do you do if the patient presents with a sample that is in pinkish color rather than opaque in color? This is a fairly common condition called hematospermia. Now, hematospermia may indicate red blood cells in the ejaculate. As opposed to the normal gray opalescent color of the semen, you may have a pinkish or brownish color. Now, the first step is typically to reassure the patient. I commonly see patients who present with a history of trauma, whether it was through sexual activity, riding a motorcycle, or an injury to a perineal area that resulted in the hematospermia. Other causes may be iatrogenic, such as a prostate biopsy, or infection, inflammation, or a number of bleeding disorders. Patients should be reassured that the hematospermia will likely clear after several more ejaculations, and the specimen can be recollected if needed. Second clinical question is a patient who presents with low semen volume, less than 0.5 mLs, after the 48-hour recommended abstinence period. Now, of course, the first step is to ensure that the patients complied with the abstinence interval, and two, to make sure there was no problem with the specimen collection. Now, the specimen collection can be a difficult or awkward scenario for many men, so we want to make sure that the specimen was collected completely in the cup and nothing spilled out, and to ask if the specimen was a normal volume that they see on a day-to-day basis, or if there was any difference in the volume of this particular ejaculate. Once you have ruled out those issues, it is important to know that the majority of the fluid from the ejaculate arises from the seminal vesicles. That's over 70% of the ejaculate volume is produced by the seminal vesicles. Less than 10% of the ejaculate volume actually arises from the epididymis or the testicle. So low volume can be attributed to an obstruction of the ejaculatory duct or hypoplasia of the prostate and seminal vesicles, congenital bilateral absence of the vas deferens. A common issue is retrograde ejaculation, particularly in our patients with diabetes. It is important to counsel men with diabetes that poor control can affect the bladder neck and thereby result in retrograde ejaculation. And also, you should review the medication list for these patients, as a number of medications that are commonly used, such as alpha blockers, such as tamsulosin, can result in retrograde ejaculation. Previous surgical history should also be elicited, as surgery on the bladder neck or prostate can result in bladder neck damage and retrograde ejaculation. A history of neurologic or spinal cord injury or issues can result in failure of emission. And finally, testosterone deficiency or androgen insufficiency can also result in low semen volume and can be tested for through laboratory blood work. Our third clinical question is, what if a sample is very viscous and does not liquefy after 60 minutes? Now, it is controversial, but some studies indicate that increased viscosity may impair motility and thereby fertility. The cause for this is the prostate secretes a proteolytic enzyme called fibrinolysin. This is what facilitates the liquefaction process. Now, if there is prostate dysfunction, frequent ejaculation, or an ejaculatory duct obstruction, this can impair the secretion of fibrinolysin and thereby affect the viscosity. All right, so our fourth clinical question is a patient with normal semen volume, but there is no sperm seen in the ejaculate. This is a condition called azospermia. Azospermia is defined as the complete absence of sperm after examination of a centrifuged pellet on 2 separate occasions greater than 2 weeks apart. If this is confirmed, the next step is to determine whether this is obstructive or non-obstructive azospermia. Non-obstructive azospermia can be broken down into pre-testicular causes, which are primarily hormonal, such as hypogonadotropic hypogonadism, such as Kallmann syndrome, or testicular, where there's an intrinsic problem with the testicle, whether that be genetic, environmental influences, a varicocele, cryptorchidism, etc. Now, an obstructive azospermia is considered post-testicular cause of azospermia and is more likely an obstructive process, such as ejaculatory duct obstruction, a history of vasectomy, or a history of infections, which can lead to scarring and ultimately obstruction. Here we have a flow chart that can help elicit or determine the type of azospermia. So on initial exam, both vas deferens should be palpated. If there is absence of the vas deferens, you should investigate further with CFTR gene mutation in both the husband and their partner. If there is the vas deferens present bilaterally, you should look at the semen volume on the semen analysis. If it is a low semen volume, you should assess for retrograde ejaculation, and that is done by assessing for sperm in the urine. If there is no evidence of retrograde ejaculation, the next step is to perform a transrectal ultrasound to evaluate for ejaculatory duct obstruction. Now, if the patient presents with normal seminal volume, we typically use the testicular axis and the hormone FSH to help identify the cause. And testicular axis of greater than 4.6 centimeters and a follicular stimulating hormone level less than or equal to 7.6 has a sensitivity of 96% in identifying obstructive azospermia. However, a testicular axis of less than 4.6 with an FSH greater than 7.6 is more predictive of non-obstructive azospermia. Now, an entire lecture can be dedicated to the diagnosis and management of azospermia, but for today's lecture, we'll have to just stick with the basics. Now, question 5. Normal volume and motility, but sperm concentration is low. So this scenario, the definition of low sperm concentration less than 15 million is defined as oligozoospermia. Now, the AUA, ASRM, and the EAU all recommend an endocrine evaluation in men with oligozoospermia. The minimal hormonal testing should be testosterone and FSH. However, you can include a number of other tests, including TSH, LH, prolactin, etc. Genetic evaluation is also recommended by these organizations for men with severe oligozoospermia, so a sperm concentration less than 10 million. Now, what are causes of oligozoospermia? This can arise from a varicocele, an infection or inflammation, retrograde ejaculation, a history of malignancy, particular testicular cancer, a history of undescended understand testicle or cryptorchidism, hormonal issues, genetic mutations, prior pelvic surgeries, particular medications, or a history of chemotherapy or radiation. Once a cause can be identified, then appropriate testing management can then be performed. Clinical question number 6 is a patient with normal semen volume and concentration but low motility. The WHO defines normal total motility of being greater than 40%. So motility less than 40% is defined as stenozoospermia. If motility is less than 0% or near 0%, we commonly perform vitality testing to differentiate between necrozoospermia or stenozoospermia, which is viable immotile sperm. Now we'll have a lecture later on in the series dedicated to specifically talking about specialized testing, such as vitality testing. In this patient, where the motility is less than 20%, or even less than 10%, we can sometimes attribute ultrastructural defects in the reproductive tract as a cause for the low motility. Clinically, we commonly counsel patients using the total motile sperm count, which is a combination of the total semen volume, the concentration, and the motility. Using the total motile sperm count, we have found this to be more predictive of predicting natural conception rates as well as success with assisted reproductive techniques. The last clinical question is a patient with low concentration and poor motility, less than 10%. Once again, the causes of oligozoospermia are listed here. Appropriate clinical history, physical exam, blood work, imaging may need to be required to assess for the possible causes of this condition, which is oligostenozoospermia. In conclusion, we have gone through a number of different macroscopic and microscopic components of the semen evaluation, which are a critical and important part of the male fertility evaluation. Now, there can be significant variability among semen analysis, as we know, but appropriate patient counseling prior to collection and a clear understanding of the various components of the semen analysis is essential for the proper evaluation and management of male subfertility. Thank you.
And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ASRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.